How are you? It's Antonio at Yale. I think Henry has a shift today, so he asked us to just introduce you and moderate, if that's okay with you.
I think you're mute right now.
Oh, crap.
No, not you. I think.
Oh.
I think you're still muted. I think.
Is
There
that-
you go.
hear me?
Yeah, you're good now.
Okay, okay, good, great. Okay, well, I am ready to share my screen whenever you guys are.
Cool.
Do we have? Oh yes. On.
Do you want to try and share it?
Okay. I think did you make me the moderator?
Oh, okay. I don't even know if I have the
It's up to
credentials to.
click that. No.
No,
I feel like it's-
you don't have a. You don't get a share screen icon at the bottom row.
No.
No, no. I also don't see that you're the moderator.
No, we don't. He didn't give us
Let
the
me-
moderator
Let me
privilege.
talk to Henry here.
Oh, myself.
Okay, now I see your screen.
Yeah, I just put I just clicked the regular link that got emailed out by Henry. So it should be the same one.
Is that what you're using as well? That email that went out and that link through
Yes.
the email that Henry sent out?
Yeah.
But you don't have
Yeah.
you don't have
I
the
can't
screen
even-
share
I
button?
can't even show. But now I can't show like where that row is.
Video.
Have you seen, do you know what we're
Maybe.
talking about though? The share screen button on the bottom? Like you've seen it before on
Yeah,
Zoom?
yeah, but it's on the bottom of my Zoom. It's when I go to more, I can't, there's no link to share screen. What if, no, that's not it.
Do you see like the part that says like participants and chat?
Oh, hold on. No, I see Henry's on and.
Henry's here
he's
now, but like-
Yes.
Okay.
Hey, how you doing?
Okay, I think we're good.
Okay,
Okay.
yeah.
Sorry, Henry.
Yeah,
I think we're good now. Sorry, man.
Oh, no problem. No, I just was going to log in so I can say hi to Eric and tell him that that you guys will be facilitating the session since I'm going to be probably in and out of listening in.
Yeah, that's been my story over the summer too. Every Thursday I seem to have a shift in the evening.
Great. Cool topic.
Okay, so you guys see my screen?
Yes, we can see it.
Yeah.
Looks
Okay.
good.
Let me know when I should start.
Usually we start like 1:05 to give enough people a chance to sort of like log in and stuff. So
Okay.
Erica, just completely aside, how is your patient load in Israel nowadays? Because it seems here in the Northeast it's getting a little crazy here. How are you guys doing over there?
How is, say that again?
The patient load, like, are you seeing a lot of patients or not?
Yeah, and we're back to where we were, I think, before COVID. Our biggest challenge has been what to do with all of the kids who are suspected COVID. We don't have that many isolation rooms, and so we've converted a lot of our like I have a casting room that's used as overflow isolation if a child is suspected to have COVID or is in isolation. A lot of kids, they have a COVID exposure and they go into isolation, and then they jump up and down on their couch and they fall or have a fever or some other reason to come in, and because they're already in isolation for a COVID contact, so we need to find an isolation room for them. So a lot of times we'll put them in my casting room, which means that the kids who are not in isolation, who need a splint, they need to go to the orthopedists on the other side of the hospital, and it's just it's a headache for everyone. But the volumes have come back to normal. And COVID, like in the last couple of weeks, has become almost exclusively a kid's disease. We're highly vaccinated out here. So most of the serious COVID we're seeing are in adults that have not been vaccinated. The kids just don't really come in with serious COVID. We had a kid in the Tel Aviv area, a 16-year-old whose parents refused to have him vaccinated, and he came in with, I think, the worst COVID anybody out here has seen. He's now on ECMO. So every once in a while we get like a bad PIMS or a bad severe COVID, but it's rare in kids. It's mostly the adults who have not vaccinated.
Yeah, we just had our first MISC case that I can recall for this Delta season, with like 20% ejection fraction on a kid who presented with multi-system lab findings and undifferentiated shock. Had pretty poor function on bedside.
What are you guys
Who's
calling
turning
it,
the
PIMS or
turning the
MISC?
corner in the ICU right now? An 11-year-old.
Yeah. Wow. That's young. Most of the severe cases that we're seeing are in the teens. And they're rare.
For MISC, you're saying, or the most severe
Severe
ones?
cases are in adults, and
Yeah.
most of the volume is in kids. The kids come in and they've got, fever for a day, and it turns out they have corona. And then I get a
Yeah,
call
that's typical.
from our epidemiology nurse, who was very concerned about whether I was wearing an N95 mask during my encounter with them. And of course I was, because that's, I wear N95s with everybody now, because who knows?
Mhm. Yeah, me too.
Yeah. And I think I'm seeing more respiratory COVID in kids now than we saw in the first waves. The first waves was mostly, a lot of gastroenteritis. And now it's a lot of just fever and respiratory stuff. What are you guys calling it out there? Is it PIMS or MISC? Is there consensus?
MIS. What is PEMS? I guess.
MISC.
Yeah.
MIS was the original. That's what we're still calling it out here. Is MIS is yeah, I guess the alternate name for MISC.
I've heard people
Forget what it
pronounce
stands-
it different ways. Some people call it MISC. I've heard. For
MISC,
Missy. I think I stick with MISC.
MISC sounds better.
I think so.
Henry, do you want to get started? Are you on? Are you?
Yeah, I'm on. Yeah. So I was realizing the time. So yeah, so we can get started. So good afternoon, everyone. So thank you for joining me today. Sorry, it's a little hectic out here, but today we're gonna have Eric Scheier, one from the Kaplan Medical Center in Israel, presenting for us again. So thank you, Eric, for presenting, and then Rahul and Toyo, thankfully will facilitate. So thank you guys for facilitating the lecture as I try to maintain this ED afloat.
All right. Well, thank you very much for having me again. It is a pleasure to be here. My name is Eric Scheier, and I'm going to be speaking about POCUS for pediatric long bone injury. And I do have a lot of slides with a lot of the literature. I'm going to skip most of that in the interest of time. I'll just show you guys that, I mean, I'm speaking, I assume that in the audience are authors of these papers that I'm presenting. So I'm just going to show you that they're there and then show you a lot of my own images. Really what I'm doing with POCUS in long bone injury. But first, what I want to do, this is a picture of my hospital from the rear parking lot. This is the rear entrance and the front entrance. The rest of the hospital parking lot, every once in a while, we'll have a Bedouin shepherd bringing his sheep through the parking lot. And so it's an interesting area. We serve about 1 million Israelis of all walks of life. And our volumes are about 27 to 30,000 a year. And first, a thank you to Dr. Tug for his talk last week. So the very next day, part of what I do is on weekends, we round the inpatient ward, and his talk was Thursday night, Friday morning, or Thursday night for me, because I'm 7 hours ahead of Eastern Standard Time. So Friday morning, I'm rounding, and one of my patients is a 6-year-old girl. She's now on day 2 of hospitalization for fever and stiff neck. She came in, she had a white count and a CRP that were through the roof. And so assuming that she had a deep neck infection, they started her on ceftriaxone and clindamycin. This was originally Rosefin and Clinda, but then I read the disclosure I had to sign and changed it to non-proprietary names. She had already seen ENT that morning, and ENT, we're getting so POCUS savvy in our hospital that our otolaryngology residents are doing their own POCUS. And so they scanned her neck and they found big submandibular nodes, and they said, well, I don't know, maybe she's got just bad lymphadenitis, and so we'll keep her on Rosefin and Clinda. So their POCUS was, I don't know, about 8 in the morning. I see her at about 9 in the morning, and I scanned her too, and I found she's got, nodes. I'm gonna start looking around, and she's got, so now I'm looking, this is kind of an oblique view. You can see a little bit of her thyroid poking through here, and she's got a tonsil. This is her tonsil here, and here I'm looking at this hypoepigenic area that looks kind of abscess-like. And so I put some color on, and you can see it's right on her vessels. This is an abscess. So now I found she's got a deep neck space infection that I call parapharyngeal. I look, this is a sagittal view. We're looking here at her vertebrae, and here's the soft tissue on top. And I didn't see anything that looked like that Dr. Tung's images from his speech. And so I didn't call it a retropharyngeal abscess, I called it parapharyngeal, but 2 days later, they found exactly the same thing. Here's our little abscess, and it's not so little. I was just, I had found the very tip of it, I guess, and it extended up. It was about 3 centimeters. And bottom line was, it shed light on her condition and decreased my cognitive load because now I knew what she had, but didn't really change management because she got better on Rocephin and Clinda anyway. So that was good news for everybody. It was just kind of fun, to have the self-confidence to say, "Hi, I can do this too," and to find an abscess.
Super cool,
So-
Eric. And that looked like linear probe. Were you submandibular in your approach, or were you sort of more down in the neck, as Dave showed us last week?
I'm actually right under the angle of the mandible here. I'm right under the angle of the mandible, kind of in an oblique orientation looking up because she's squirming, and it was really hard for me to get this view where I'm looking at tonsil, where I found a landmark, I'm looking at tonsil. So once I could see that she didn't have a peritonsillar abscess, then when I just kind of fanned, I'll call it up and down because honestly I don't remember which. I'm in an oblique orientation right under the angle of the mandible, and that's where I found this abscess, which is. My assumption is that I'm looking at the tip over here because the angle of the mandible would be here, and I'm just not able to see all the way up here. There's no way I'd be able to image the more cranial portion of her abscess. But I thought that was pretty cool. So thank you for last week's lecture. The use of POCUS can show us torus fractures, can show us where the fracture is. I use it a lot in fracture reduction. I do my own reductions, and I've done quite a few under. We don't have a CA, so we do it under POCUS. And I mean, from personal experience, I can tell you this is very effective. I have had only one. I've done about 100 so far, and I've only had one that I missed. And that was because the fracture was inherently unstable and it moved during casting. But I mean, in all cases, and these are only distal radius reduction, or distal forearm reductions, we'll call them. I'll talk about that in just a second. But in all cases, I can see after the reduction that I'm anatomically perfect. And I'll speak a little bit about radiographically occult fracture because I think that's an interesting topic that I don't know enough about. The use of POCUS to find upper extremity fractures, at least in children, is at the point of systematic review and meta-analysis. We have enough literature so far that we can build these papers, and current evidence suggests that ultrasound is an excellent diagnostic tool to find fractures. And there's a validation study which showed that, again, the test parameters were excellent, and they found that the more you do it, the better you become. So here's case one, a 7-year-old male. He falls from playground equipment, injured his left arm. He's x-rayed in the community, and in our setting, I work for a hospital that is owned by an HMO, and so they own outpatient facilities, and the data center is integrated. So if they're in our HMO, I can see everything, including all their films. If they're outside our HMO, I can still see a lot of their data. I can still see a lot of their lab results, but I can see lab results on any Israeli, but I can't see their films, and I can't see, sometimes they have doctorate notes that I can't see. Excuse me. And so the child, he didn't bring a disc, and he's not affiliated with our HMO, so I can either send him again for an x-ray, which he just had a few hours ago. They just forgot the disc. So what do? So I can put the probe on. This is not that child. This is a much younger child, you can see, but I'm looking over the distal radius in a dorsal, lateral, and palmar orientation. And I get a sense for his fracture. So here we're looking at, this is the child. We're looking at his normal side and abnormal side from a dorsal and palmar orientation. I left out the lateral. Actually, I didn't leave out the lateral. This is actually his lateral. So from a dorsal orientation, I can see that it's not terribly angulated for a 7-year-old. He's got a buccal fracture. I can see here, this is acceptable angulation for a 7-year-old. I'm not aware of any literature that shows that you can measure the angle of a child's fracture on POCUS because you're looking at the sweep of the cortex rather than an angle you usually take from the mid-epiphysis down to the base of the ulna. And but I mean, if you say that a 7-year-old can get away with a 20-degree angle, then this is good enough for government. So I splinted him and sent him for follow-up, and he did just fine. Turns out that I was right. This was an acceptable angle. But the point is that with POCUS, I can get a really good sense of what the forearm fracture looks like. And there may come a time when standard of care is, if my pictures are good enough, not to send him for radiography, especially in simple buccal fractures. I really don't see the need for it. And so neither did they in the Netherlands. They were looking at children. Basically, can POCUS find distal radius fractures? And one of the interesting things in this study was that they spoke about pain scores being comparable to, or actually it was less painful to have POCUS than it was to have an X-ray. So if pain is not an issue and the accuracy of POCUS is as good as X-ray for simple, minor forearm injuries, especially forearm injuries where you might not even need a cast here. Our standard of care in a simple buccal fracture is just to put on a removable splint. I tell them in the old days when I was a resident, we were casting these kids, and we got away from casting to splinting. I remember that we would put on splints and we would say keep it on for keep it on for a month. In that period of time, you're going to see your orthopedist. And now I tell them to put on a removable splint. I tell them to wear it for 72 hours just for pain control. And that window of time is, in my opinion, that's when the swelling goes down. And after 72 hours, they should feel good enough to be able to take it off. They can shower without it. They can, they should be getting to the point within about 2 weeks where they're really using it ad lib as needed, and then they can throw it in the garbage. And they can go see their pediatrician. And these are minor, clinically not very relevant forearm injuries. And so I think that POCUS is a fantastic modality to just put a probe on, find the buccal fracture, and give them some form of immobilization and send them on their way. So you ask me, what about the ulna? Well, number one, I can see the ulna if I really wanted to. Number two, in young kids, there are no ulnar styloid fractures, so I really don't need to see the ulnar styloid. A lot of times in older kids, you'll have this isolated ulnar styloid fracture, which also just needs immobilization, but you do need to know about it. Non-angulated radiobuccal fractures are generally not associated. Hold on a second, I am going to just move so I can see what I've written. They're just not associated with ipsilateral ulnar shaft fractures very much. And if they did have a styloid fracture, it wouldn't change management very much. And lastly, in fracture reduction, the ulna always follows the radius. So if I have a reduction and my radius is and now has acceptable angulation, even if my ulna doesn't, it'll grow into it. It'll follow the radius. And so if my radius is acceptably reduced, then I don't have to worry about that. So we'll move on to localization of fracture. This is a case of a 13-year-old who fell off playground equipment onto his left shoulder and he hurts. And he's transferred by our EMS system for evaluation of a shoulder dislocation. And I'm seeing here that, so this is in Hebrew, this is his triage. His triage chief complaint is shoulder dislocation, because that's what they took down from the EMS report. So does he have a shoulder dislocation? Well, I can look at his shoulder. I'm looking at the humeral head. This is my glenoid. Here's my deltoid, scapula. And this is the joint space. So if my humeral head is opposite the glenoid, I'm not dislocated. I'm located. So why does he hurt so much? Well, he's got a proximal humerus fracture. And this is all in the first 30 seconds of me meeting him. I mean, I'm talking to the parents about what happened, and I already know what he has, and I know what he needs. You can see here, I'm just fanning through. He's got some, soft tissue swelling above the site of the fracture. It's a fracture that looks exactly like this. So this is our not so lovely film. This kid didn't take his necklace off. So we've got a fracture line here, and so if in this case, it didn't really change management. It's the same film in the end, and I would have seen the proximal humerus fracture, but it decreases cognitive load. In a lot of cases that I'll present in just a second, instead of imaging the entire extremity, I can just focus in on the area where I found the fracture. A lot of times I am sending them for x-ray because my orthopedic consultant can't see my POCUS, or in follow-up, they can't see my POCUS. So just to have something on record. And so one of the things that I wrote in the last year or so was this case series that argued for a quick screen of the upper extremity in a kid who comes in and he looks like a pulled elbow. He doesn't have any obvious swelling, and he's just kind of holding his arm, just kind of, there's a word for it in Hebrew that I'm blanking in English, but just kind of his arm is linked by his side. He looks like pulled elbow, and just screen distal radius, supracondylar area, and proximal humerus. And if you don't find a fracture in any one of those sites, that raises the odds that you have a pulled elbow or a radial head subluxation or a nursemaid's, or however you want to call it, depending on which area of the world you come from. It raises the odds that you have a pulled elbow greatly, and you can feel confident trying to reduce or looking further to find pulled elbow on POCUS. We'll talk about that in a second. But that's how we work. That's what I do. And so if a kid comes in, there have been, there was a study in the literature recently that showed that a lot of these kids who have stories consistent with pulled elbows are actually fractured. And a lot of times when a kid falls, he falls grabbing something. And so what you think is a fall outstretched hand is actually a pulled elbow. So I think that this screen helps. And we'll talk about these other areas in just a second, but I'm gonna jump for a second to pulled elbow. This is the view. So you want to be across the, you want to bridge distal humerus and the radial head from a palm up orientation. And you get this picture. This is distal humerus, and here's my joint space, and this is my radial head with my supinator and my annular ligament, which have been pulled in. This is called the hook side. And in a pulled elbow, the annular ligament pulls the supinator forward, and the annular ligament gets caught in the joint space. That's what hurts. This is from a study in 2014 showing basically the same thing, but they marked it up very nicely. You have the capitellum here, your annular ligament, your supinator, and your radius. And this is in a normal arm. Here you have the supinator and annular ligament pulled into your joint space, causing what's called a thickened synovial fringe, which you can see better on these images. This now here, it's reversed. The healthy side is here, You have a normal synovial fringe, and you have the orientation also here is reversed. The humerus is on the right side of the image, the radius is on the left side of the image. So your supinator is here. And you can see the supinator basically ends at the end of the radius. It doesn't get pulled in. But here, your supinator continues on past the border of your radius, and you have what's called a thickened synovial fringe. And that's a pulled elbow. So that took me a little while to learn. I learned the basic screen before I learned this. And so I think that, especially for beginners, doing a basic screen of distal radius, supracondylar area, and proximal and humerus shows you that you don't have the three most common areas that are fractured in young children. And so we'll move on now to fracture reduction. Actually, I'm doing okay on time. And fracture reduction is, like I said, I use POCUS always in fracture reduction. And some of them I do, and some of them the orthopedists do, depending on availability, depending on how complicated the fracture is. Sometimes they'll want to reduce a midshaft that I don't really feel comfortable doing. And so, so I give that to them, but I'm always in there. I mean, I'm on the side of the sedation anyway. So I'll wheel our Zonari machine in and guide them. So this is a fracture, just to show you how we do it. That is reduced. You can see that same fracture on POCUS. From the three orientations, you've got, this is going to be a dorsal orientation, lateral, and here's the palmar orientation. And here are our fracture sites. And this is the post. So you've got, again, dorsal, lateral, and palmar. And you can see that it looks really good. And to me, a lot of people want to do it by feel, or they want to do it. C-arm is just a lot of radiation. And it's big and it's bulky, and we don't have one. To do it by feel, a lot of people with, I've worked with orthopedists who have 30 years experience, and yeah, they can do it by feel. And a lot of times in those reductions, you're left with 8 degrees of residual angulation on the follow-up film, and it's good enough. But there's nothing better than perfect, especially if you're putting it in a cast and having them follow with orthopedics. There may be movement within the cast over the next several weeks. And so if you start from perfect, you've got a greater range of movement that is allowed before it develops into an unacceptable reduction. So there's nothing better than perfect. And this is the post film, and you can see that that's pretty much perfect. A lot of times I think that it looks perfect, but I'm not quite sure, or here is a little bit of translation left. So looks okay to me. And I could just look very quickly at the unaffected side and see that, yeah, that's pretty much it. And that you can't do with the C-arm. So I wrote about it. That was fun. And length of stay is significantly less when we do it. The PEM reductions are excellent. This was a series of 75 that we did, and there were only 2 that were missed. One was epiphysiolysis that wasn't completely reduced, and that may have had something to do with thumb strength. Big kid. And there was another one that was my unstable fracture that was perfect on POCUS, and then it just somehow moved in casting. And there's really nothing you can do about that.
Eric, we have a question coming in from the group at Cohen's. Whether you do this with all fractures or just choose specific ones, in terms of how much shortening, only the mildly angulated cases, or is it sort of a all size fits all for POCUS reduction at your shop?
Well, we do all reductions under POCUS. Whether the orthopedists do it or whether we do it, again, depends on, there's no real rule. It depends on the availability. It depends on the individual PEM physician, whether they feel comfortable doing a certain fracture, and that depends on their level of experience. We have we only have 3 PEM docs who are full-time, 2 part-time, and 2 fellows. So we're not a big shop. So it's variable. But if their distal radius and it's one of the full-time PEM docs and the ER is not slammed, we're almost always doing them. So here, so this was one.
I'll let you do this case. Other questions are coming in, but I'll let you get through this case, Eric. People are very interested.
Oh, okay. I actually have, I'm sorry, I haven't been looking at the, I guess I should look at the chat box.
No,
We
that's our
got you.
job.
We got you for the chat box.
Okay, okay.
Why don't you get through this case and then we'll see what else comes
Okay,
up.
so this case actually came in, this is a case that I did on Thursday. And you can see it's, you know, it's 100% transet. It's got a little bit of shortening. And this is a 14-year-old. So not a small kid. And the orthopedic resident, let's just say that I was probably stronger. So she got stuck here. So I wound up doing this reduction. I called her in because I needed to do the sedation because our residents we had a very busy ER that night and there were no residents available for sedation. So I didn't want to do both at the same time. So I did sedation, called the resident in for the reduction. And I wound up doing both because she got stuck. So in follow-up, what did I do? There we go. Perfect. Okay, you've got a little, I mean, this is just perfect. This is the dorsal, and I did not, it's a little bit undergained. So I just hope you guys can see this is the epiphysis, this is the physis, and here's the distal radius dorsal aspect. And this is the palmar aspect of that same radius. You've got the epiphysis, the physis, and your distal radius. And it's perfect. However, moved a little bit in casting. And so she did the casting here, and I was holding it up. So this actually may have been my fault. But a little bit of dorsal angulation, and it's more than an acceptable reduction. And hopefully this will not move. But you can kind of see what can be done under POCUS. I think that this was one of the more difficult ones that we've done. Bottom line is with POCUS, I can tell you without a shadow of a doubt that the angulation, that the reduction is perfect and that we can cast in that position. And almost always the follow-up x-ray proves that the POCUS was accurate.
Eric,
and that was some.
Are the orthopedists at your institution also utilizing POCUS? Or it's another question that came in.
Not really. They come in, they're very much, they're for POCUS. They've learned to love it. There's a rumor going around that they actually want their own C-arm. We still don't have one. At the very beginning, we had a few more experienced orthopedists, again, coming with 30 years of experience, who would just come in. They'd be like, ultrasound, what do I need that for? I can feel that it's in. So why, you know, I can feel that it's straight. So let's just cast it. These are orthopedists who they could just do the reduction within 90 seconds and be done, and then move on. And as they've gradually been replaced in these reductions by a younger crew, more and more, and I'm seeing this across different fields. There's more and more uptake in our facility for POCUS. Orthopedists, like I said earlier, the ENTs have started doing it in their clinic. We've got urologists who will come in and do their own testicular ultrasounds after we started doing it. I'll come in, I do a little bit of QI for POCUS in our year, and I'll come in the following morning and I'll see that one of the urologists they've done the testicular ultrasound in the ER, and so I can talk to them about that. But there's just in the last couple of years more and more uptake of POCUS in our shop, which is very encouraging. And the orthopedists also, the residents who come in who help us with the reductions, they know that ultrasound is part of the package and they love it. I can show them. It takes a fraction of a second to just pause the reduction, put the probe on. I can show them it's straight or it needs another, what we call a kvetch, just another little manipulation, and we're ready to cast.
Presumably the gel doesn't cause issues with, sort of generating the traction that's required. Do you wipe it off and then reapply?
No,
Post-procedure?
so wipe it off. And also I'm not doing POCUS on the areas of traction. So if I need, for example, this fracture up here, so what I'm doing is I'm, what's the word in English? I'm basically worsening the fracture. Okay, I give it dorsal angulation in order to try to clear this fragment here under traction. And so for that, I do need my thumb right here to try to push this fragment forward while I'm dorsally angulated. And so I'll just wipe the gel off. I don't really have, the rest of my hand is on the wrist, which is not gelled. I keep it right here. And then I wipe it off before casting. So the gel really doesn't get in the way. It can be, I mean, if you have an open fracture, that can be tricky. And then I'm not using gel, I'll use sterile saline. I'll use sterile saline in a sterile glove and do it that way. But otherwise, it's a very quick, we do a manipulation and then I'll just do a dorsal lateral palmar, store 3 images, and either we're good or we need to do another manipulation. And then I come in again and do another photo. Each time I come in to take images, it's talking about under a minute. I mean, it's quick. So the orthopedists really do appreciate POCUS. Okay, and this group in Turkey recently, as of last couple of months, have also similarly found that POCUS increases the success of the reductions, and there was high agreement with POCUS and their X-ray images. And so POCUS is good, because I'm preaching to the choir here. So radiographically occult fracture was another interesting topic that I wanted to bring up. This is a 17-year-old wiped out in a shopping cart. I guess they're doing down the street. So actually this kid, this is an interesting case because again, I'm Saturday morning and I'm rounding on the floor, and he was hospitalized overnight. He came in like 2 a.m. The residents decided to keep him as trauma obs, and the trauma surgeons came in and they cleared him as far as head and abdomen, and the orthopedist read his elbow films as normal. So I came in, I do regular rounds and then I do POCUS rounds, and I didn't see this film. This film it's not normal, but I can see how the on-call orthopedic resident missed, this is subtle, okay? I mean, you need to be maybe not working for 18 hours straight in order to see the anterior fat pad and a little bit of posterior fat pad. Here's an AP, which is normal, but on my POCUS, this is very abnormal and it jumps out at you. And so he's got hemarthrosis. This is distal humerus here, capitellum. Here's your triceps. And this is the posterior fat pad. This is actually the fat getting pushed out by blood, by hemarthrosis. This is the posterior aspect, and this is the anterior. Here I'm looking at the distal humerus again, but from the anterior aspect, and this is his anterior fat pad. Again, this is the fat pad itself, and he's got a hemarthrosis, which is pushing it out. So what is subtle on X-ray I think, is very clear on POCUS. And so that's not an occult fracture, that's a missed fracture, but still, elbow fractures are highly radiographically occult. Sometimes it's hard to see them on these lateral films. And up to 12% ED misinterpretation, especially junior doctors. So if you have a film and you're not sure or you think it's normal, do a POCUS, because sometimes that fat pad will jump out at you. SEPFP is my abbreviation for sonographic elevated posterior fat pad. And there's high sensitivity and decent specificity for elbow fracture when you find this on POCUS. It is highly sensitive and decently specific. So it's not always an elbow fracture, but most of the time, you know, it's worth putting in a splint. And when you have lipohemarthrosis, which is that mix of fat and blood in that what's called the olecranon notch, that's a more accurate predictor of fracture than just having an effusion. And the specificity there reaches 85%. So most of the cases which wind up being fractured are actually lipohemarthrosis. And I'll show you a few more pictures in just a second. With 85% specificity, it's worth just putting a splint on and having them followed in the outpatient clinic as supracondylar fracture if you have this finding. It can be found rarely without fracture or in pulled elbow. Pulled elbow, you're not going to have a lipohemarthrosis. You're going to have an elevated posterior fat pad. So it's not going to be, it's not going to have those distinct intra-articular layers that define the lipohemarthrosis. Usually it's just a small effusion. You can have fractures that don't have an elevated posterior fat pad. So you can have medial condyle or proximal radial fractures are the two that are known to present without elevated fat pads. And so this is what I do. There are some authors who have developed a much more comprehensive elbow scanning protocol, which is a little bit beyond my ability. I've started to look at lateral medial condyles, and I'm just not seeing it. But like one of the first papers, the validation study for POCUS in upper extremity injuries showed, practice makes perfect. The more I do it, the better the test becomes in my hands. It's user dependent. So we look at the olecranon notch in sagittal orientation, and the text tells us to look in transverse orientation. I personally, other than finding fracture lines in the olecranon, finding fracture lines in the condyles, which I've not yet done. I don't see what the point of a transverse view is. I see the effusion perfectly well with the sagittal, but you know, this is another 15 seconds of my time, so why not just swivel the probe and look? And these are the pictures you get. Again, here's your distal humerus, triceps, and this is the posterior fat pad. So you've got these intra-articular layers, you've got fat, you've got blood, and that's a lipohemarthrosis. That's actually a case of a 6-year-old who fell from a swing, injured left elbow, and his exam is very suggestive of a fracture. So here are his films. I guess, I call these normal. I saw this kid, this is actually an older case, maybe a year or two ago. I call these normal. He's not this, you can argue whether this is a true lateral. I thought this was a pretty decent lateral. I don't have a posterior fat pad. I don't have an anterior fat pad. I don't have my anterior humeral line, my radiocapitellar line line up. I don't have any signs of fracture here. But my POCUS looks like this. So again, this is an elevated, this is lipohemarthrosis here, not just an effusion, but you've got your fat mixed in there too. And on follow-up radiography, 15 days after injury, so you can kind of see callus formation around his lateral condyle. This kid had a fracture. And POCUS helped us to build a case for putting him in, for immobilizing him and having followed with orthopedist as fractured. And this is another case, a 6-year-old, similar case. Again, we can argue about this, is this an anterior fat pad? Even if it is, the specificity of anterior fat pads alone for fracture are much, much lower than posterior fat pads. I don't see a posterior fat pad, and I don't see a fracture line. So, what did he have? So this kid also, he had a non-displaced lateral condyle fracture that in hindsight, maybe I'm seeing here. And yeah, this is also an older case. I probably didn't notice this, but the focus sold me on the need to put him in a splint and have him follow with the orthopedic clinic as fracture. So I've got a whole bunch of cases like this where the lateral, it looks okay to me and the focus looks very not okay to me. I don't have enough data on the follow-up of these kids to say who's fractured and who's not. So I'll just throw that out there for fun. Here, the other advantage of a POCUS is helping to clarify films that are not as good as you might want them to be. And this is a kid who they didn't remove the sling before they shot the lateral. So we're looking, all of these, this haze is his sling. The AP you can see is unremarkable. And the lateral, I don't see anything. On the POCUS, I sure do see something. He's got an elevated fat pad. So I spoke to our orthopedic consultant, and their argument was we need a true lateral in order to know for sure. And my argument was I have a true lateral. I have this. There's nothing that you're going to get from repeating the X-ray. There's nothing you get from repeating the X-ray that I don't see on POCUS. So in the end, we wound up repeating the X-ray and saw his fat pads, but I'm not sure why. This kid also, you can make an argument. Here I have, this is also an older case, but a kid who, we've had so many like this. I think this kid was about 2, and he hurts. You can't get him into a true lateral. You can see how hard it is to get him into a 90 degrees of flexion at the elbow. So I got basically 2 obliques. And then if you add POCUS, I see his posterior fat pad. I can see that he doesn't have an angulated supracondylar fracture. So that sold me on he's fractured. So we put him in a splint and sent him for orthopedic follow-up. Maybe in hindsight, you can say maybe this is a posterior fat pad, but it's so much clearer on POCUS. And here is follow-up films. You can see callus formation in the supracondylar area. So even in follow-up, they couldn't get a real true lateral. So I think that once you have a decent X-ray series, the POCUS, the sagittal view of the distal humerus becomes your true lateral. This is a kid. Oh, I throw this image in because this was a kid I actually just saw 5 hours ago. And again, this was a kid. So this is a 7-year-old girl. I don't remember how she injured herself, but these were images that I didn't see until after my POCUS. She'd been seen 2 days earlier at a facility that read these films as normal and sent her out with diagnosis of contusion. And I can see how, again, I don't know, maybe 18 straight hours of work or just a very junior physician, you can see, you may actually not be able to see because these are my cell phone photos. I didn't have enough time to download these before I left the hospital this afternoon. But there's a posterior fat pad, there's a little bit of an anterior fat pad, and you can see a radial head fracture here. But anyway, I can see how I can see how this would be missed. These findings are not as clear as you can see on POCUS. So here's our POCUS, and this is my transverse view. You can see the 2 condyles here. There's 1, here's 2, and I'm basically fanning cranial caudal. And I'm looking at her effusion in the olecranon notch, is again that mix of fat and blood. And you can see, I guess, after she's now 2 days after injury and it's settled a bit. This is the sagittal view of distal humerus, and here's her elevated fat pad. So these very subtle findings here are clear as day on POCUS, and you can see her anterior fat pad clear as day here. Here's her effusion. So I think, especially for junior physicians, this is an excellent tool in clarifying areas that may not be so clear in X-ray. And here's her radial head fracture from these are two different orientations, lateral and I don't know. This is her palm up. This is kind of sagittal anterior, you could call it, of her radial head fracture. And here's the fracture. So POCUS makes clear what radiography does not. And I'm actually gonna skip these in the interest of time. I see we've got about another 10 minutes, and I did want to show you some other interesting photos of mine. Jenny Raven has done a lot of work on elbow sonography and finds it to be a highly effective tool, and most effective is and there's enough, like in upper extremity injury, there's enough literature now that we have meta-analyses, and it is a highly effective tool to rule out fracture. So if you have a physical examination that's not very suggestive of fracture, and you have a normal olecranon notch on your POCUS, you can feel more confident saying that the child does not need to be immobilized. Bernier wrote a series of 13 cases where basically he's an orthopedist in France, and these are kids who were seen in the ED, and like in my cases, the X-ray looked normal, was normal, and they were discharged because their examination was suggestive of fracture. They were discharged, immobilized for orthopedic follow-up, which happened on average about 6 days later. And then in orthopedic follow-up, he did the POCUS, and he found 13 cases where the radiology was normal, but POCUS showed lipohemarthrosis and a fat pad sign. And he found cortical disruption in 11 of those 13, and just presence of lipohemarthrosis and fat pad in the other 2, and they're all fractured. In those that didn't have, that had negative radiography and negative POCUS, he had no fractures. So again, it's a very effective tool in elucidating elbow fractures, supracondylar fractures. And there are a few series that looked at this combination of normal radiography and sonographic elevated posterior fat pad. Not all of them are fractures, but almost all of them are fractures. So here's an interesting case. There's a lot of text that basically says there's a 2-year-old who came in with limp, and she didn't have anything. The first thing that we did was POCUS. And so all of this is kind of a POCUS. I'll show you the POCUS in just a second. This is actually a case that I don't know what the answer is. POCUS showed that she didn't have a hip effusion, but what she did have was, this is her X-ray. I got this in reverse order. So what I want to do is show you the POCUS first. This is the unaffected side. You've got a normal, this is a sagittal view of her proximal femur. Again, epiphysis, physis, and here's kind of the neck and shaft of the femur. Your iliopsoas, what's the word I'm looking for? Inserts into this area of bone. And if you had an effusion, it would sit right here. So you can see on the affected side that she does not have an effusion, but what she does have is this little chupchik, we would call it, this this area of bone that is abnormal. I thought that was suspicious for buccal fracture. So, and she's limping, so we x-rayed her, and the orthopedist looked at it and thought that there was a fracture of, I already forgotten because I thought that this was a normal film. He thought that there was a fracture of the lesser trochanter. I didn't see it. And she was admitted so that the orthopedic surgeon could see her the following day. We do that we do that a bit if it facilitates a more comprehensive workup. I think they also wanted, if the orthopedist thought that this was a fracture, they wanted social services to see her as well. Bottom line was this kid wound up going home a day later, and the limp resolved. I don't know if this was fracture or not. I think that my personal opinion is that I need to do these exams much more and get much better at this in order to be able to say with more certainty that it's fracture. We need more literature. We need more data in order to be able to say that these POCUS images are fracture, not fracture, because there are medical legal implications to our findings. And sometimes the x-rays are inconclusive where the POCUS is much more conclusive. This is a case, this is a tibial injury in a child who is, I've forgotten how old, but here is the unaffected side. This is the lateral and AP of the lower leg. I don't see a fracture. This looks pretty okay to me. But on the POCUS, you can see here's the unaffected side. And here is a little buckle fracture that this child had. I have, I'm actually, I've got more than one case here. And some of them, I even have follow-up films that show, did I put a follow-up film in here? No, I did not. So this child had a follow-up film that showed callus formation over here. So he had a fracture. You can see we're coming up on final minutes. And I think that we need more data to support our use of POCUS in lung bone injuries because we can find fractures that the X-rays cannot. So there's a little bit of literature on lower leg fractures, diagnosis of tibia and fibula fractures. This is a series of both adults and children. And he, again, very good test parameters for tibia fibula, but most of his patients were adults. He did find 3 patients where the fracture was found only on POCUS, but he didn't say who they were, how old they were. So I don't know if they were pediatric patients. And this is a paper that just came out very recently, looking at ankle injury, and the test parameters in ankle injury are less encouraging. And combination of open growth plates. This just makes sense to me. A lot of ankle fractures are too deep for POCUS to be able to see. A lot of your Salter 3s and tibial more complicated tibial fractures are actually you'll see them best on the X-ray more between like in other words on the side facing the fibula. And so this is the last case. As we went to our final minutes. One last case. So this is a 17-year-old came in. She injured her shoulder by picking up her sister. And she walks in supporting her right elbow with the left hand, and the shoulder squared off. I feel the humeral head at the posterior shoulder, and she can't move her shoulder. So what is this? It is a shoulder dislocation. That was my working diagnosis. I walked her into the procedure room. I do my reductions under nitrous. We start with some intranasal fentanyl, plus minus midazolam if they need, and then go to nitrous, and that almost always works. And I was sure this was going to be a shoulder dislocation. So first thing I do is I pick up my POCUS, and this is not her. This is a true shoulder dislocation that I had last half year at some point. But you can see here's the normal left. Here again is the humeral head and the glenoid and the joint space between the two. You've got here's the shoulder musculature, your deltoids on top, and this becomes your scapular spine here. And the humeral head sits just opposite the glenoid. This is a located shoulder. This is a dislocated shoulder where the humeral head is deep to the glenoid. Your transducer is sitting here on I'm basically transverse from a posterior aspect. I'm transverse posterior to the shoulder. And so the humeral head is deep to the transducer, which means that this is an anterior dislocation. You can see some of the fat of the effusion in the joint space here. These are just two of the same images that I was hoping between the two of them we could make sense of what's what. That here's your humeral head sitting up here, and this is the glenoid with this vacant area opposite it that indicates that you're dislocated. So this is now her. Is this her? No, sorry. This is, why did I put this in? This was a kid I had just yesterday. This is a shoulder dislocation I did, and I'm just kind of fanning through showing you that, oh, well, look, it's located. Here's the humeral head, here's the glenoid, and they're opposite each other. So let's get that. So this is her. And I'm scanning through and I'm seeing, wow, is this a posterior dislocation? Here's your glenoid over here. And this weird looking humeral head pokes through. So I thought, you know what? She needs an x-ray. So here's her x-ray. She forgot to tell me that she had hereditary multiple exostoses. She was followed by an orthopedic clinic at a different hospital for this. And one of the areas where it manifested was in her proximal humerus. And what I was looking at is this big exostosis that I, in my fatigue or lack of experience, thought was the humeral head. She did not have a shoulder dislocation. She had this weirdness of her shoulder, but that kind of put me in my place and taught me a little bit of humility in all of these focuses that I do. But I thought that was a fun case. Not everything that looks like shoulder dislocation. So in summary, POCUS can diagnose torus fractures in children with isolated tenderness or distal form. Do I need an x-ray? I don't know. I think we need more literature showing that POCUS can be standard of care in these kids. Why can't they come into their pediatric clinic, get a quick POCUS, and even an ACE-RAP? POCUS can help me choose a bone to x-ray or then x-ray the entire extremity. A lot of kids who come in and they look like pulled elbow, but I can't quite figure out where they hurt, and there's no reduction happening, or they just, they fell and you can't figure out where they hurt, whether it's upper extremity, whether it's lower extremity. A lot of times you wind up, they wind up going to x-ray for an x-ray of the entire extremity. And then you figure out where they're fractured. If I scan down the extremity, whether it's upper extremity or lower extremity, I can do a quick scan of femur, tibia, or humerus and forearm, and find the area of fracture that then allows me to focus my film just on that area, save them a little bit of radiation, and also send him to x-ray knowing what he has and moving on to the next patient. POCUS can guide forearm reduction and can give you a perfect forearm reduction, not just an acceptable forearm reduction. And POCUS can find fracture that might be subtle or absent on radiography, whether it's a supracondylar fracture that can be subtle on x-ray, or a tibial fracture that can be subtle on x-ray, or any other area where the anatomy allows me to see it better with ultrasound than with x-ray. And that's actually a point that I didn't really talk about, is why the elbow, why the proximal tibia can have these areas where fractures can be radiographically occult. It's kind of an interesting topic that we don't really have time for, so I'm going to stop there and see if there are any questions.
Eric, that was wonderful. Thanks for putting it together. I just had one question about the anterior fat pads. I'm not accustomed to looking for them. I presume you're doing these in full extension, And how do you find patients tolerate,
Mm.
the anterior fat pad evals as opposed to the posterior fat pads, which in my experience are pretty well tolerated? And then do
Actually,
you
I don't do
find
them
that
full extension.
Fu-
I
You don't?
just put a ton of gel on. I get them maybe to, I don't know, to like 70 degrees, and then put the probe on. I can see it pretty well. So I don't need full extension with these.
do you find that pretty much if the patients that have lipohemarthrosis posteriorly, they almost always have it anteriorly as well by ultrasound in your experience, as opposed to X-ray?
No, actually, I don't know, I'd say maybe a quarter of them do. Most of them have isolated posterior fat pad because most of kids who come in with supracondylars are fallen outstretched hand, and the olecranon bangs into the olecranon notch posteriorly, and that's where your fracture line is. And so you get the posterior fat, you get your posterior fat pad and hemarthrosis in that area and POCUS. And so I think, and I don't know that anybody's looked at this, but I think that posterior fat pads on POCUS are much more common than anterior fat pads. And I don't look, I've just recently started to look all the time at both sides. But until, I don't know, maybe 4 or 5 months ago, I was really looking at the posterior. So let me just go through the chats. Okay, so we spoke about that. How long did it take to develop this understanding agreement with ortho to use POCUS for diagnostic and procedural orthopedic applications? Please describe this process. We just kind of took the POCUS and brought it into the room. Again, we don't have a C-arm, so it's either do it blind or do it with POCUS. And really quickly, the orthopedists also saw that they could easily see the landmarks, and that we could guide them in the reduction and have a perfect reduction in the end. So they all learned to love it. How do you navigate the reduce issues of having gel in the area? So yeah, so I think we spoke about that. A bowl of talcum powder. I think you would, I don't know, I mean, anything that you put on, you need to take off very well. It's going to stay there for the next month because you're wrapping this, and we wrap it in a web roll, and then we work with proper plaster, the same plaster that you use for your walls. We got these rolls of plaster. So whatever, when we're casting, whatever's on the arm is going to stay on the arm for a month. So I like to have it clean. I don't know. I don't know how talcum powder would work if that would clean off nicely. But we really just, I put gel on and then I wipe it off with a paper towel. And when I want to look again, I have my tube of gel right next to me and I just put another line of gel on and look real quick, then wipe it off. And thank you very, very much. Oh, they thought that was only a joke. I don't know. I mean, I've always had this question because, you have kids who come in with abrasions over the fracture site, and we reduce them and we wrap them. I usually put a little bit of antibiotic cream on and then wrap the web grill over it. I don't know what the best way to dress is, because these are kids who are, whatever you're putting on is staying on for a month, and I want it to be comfortable for them. So I don't know, maybe talcum powder would be, getting a good grip in a reduction, especially if you're doing like a 16-year-old who's an athletic 16-year-old, these can be difficult. And propofol is my friend there, because that's how I get them loose enough to be able to be stronger than they are and reduce their fracture. But yeah, grip is an issue.
Well, thank you so much, Eric. That was awesome.
Thank you guys.
Those were great cases.
I appreciate the invite, and I look forward to next week's talk.
Us as well.
And look forward to continue to being able to participate if I'm not working.
Sounds great.
Actually, I'm going to be in the States next week, so I'll be back on your time. So hopefully I'll be more available at 1 p.m.
Sounds awesome. All right, guys.
See you guys then. Thank
Thanks
you.
everybody for your participation. Hope everyone has a good rest of the week and look forward to seeing you next week again. Take care.
Good night.
Good night.
That was great.